Hello, everyone.
Good morning, everyone. Thank you very much for coming over, and thank you very much for the opportunity to present on bone mineral disorders. I'm not going to cover all the mineral. I'm just going to cover calcium, and I think that's the amount of time we have here. And I'm going to present cases, so I would be grateful if you could, you know, I'll try to be as interactive as possible. So if any questions, just raise your hands and we'll pass on the mic so you can ask questions in between as well, so you don't have to wait till the very end. Um, so it'll be mainly cases which I'll be discussing, and these are not the common ones, but these are the challenging one, which tests our physiology and understanding of the calcium homeostasis. So these are my disclosures, and I've just got this mic so that I can walk around and ask and make it more interactive. And again, I've been supported by the International Society of Children's Bone Health to come over here. And I would just like to show the details of the society and the benefits and the membership, and would be grateful if you could join this because there are a lot of benefits which you will have. And at the moment, this is how the percentage is, and we would be grateful if we can bump up the numbers from the Asia Pacific region, and the details about the membership there. Okay, so I'll start with regulation of calcium homeostasis, and then approach to hypocalcemia and approach to hypercalcemia. And again, I'll bring in cases where we can try to make it as interactive as possible. So we'll start with calcium regulation, very tightly managed. It's between 2.2 to 2.7. Unlike phosphate, it changes quite a lot with age. Calcium, it does change a tiny bit, but on most occasion, throughout the lifespan, the calcium concentration is maintained between 2.2 to 2.7. That would be in milligrams per deciliter, 8.8 to 10.8. I have put where possible from millimoles to milligrams per deciliter, so make it easier. But that's all my calculations, so please bear with me. But the ionized calcium is mainly measured in millimoles per liter, and that's how we try to maintain it. It's mostly half of it. Again, the half of it is bound to albumin phosphate citrate. Albumin is important, and that's why we have calculations here to adjust the calcium level based on albumin concentration. For me, phosphate becomes very important because wherever you give phosphate, it binds to the ionized calcium, it brings it down, and then it increases PTH concentration. So in any condition, I have to give phosphate. I'm very careful not to give high doses, but give smaller doses frequently and increase it and measure PTH concentration, because that is going to go up. So that's about how the serum calcium concentration, and very important, it's an extracellular mineral, unlike phosphate, which is intracellular, and therefore you won't see a robust mechanism for maintaining the serum concentration of phosphate because it's pretty much intracellular. Whereas calcium, there is a very robust mechanism to maintain the concentration within the normal range because it is extracellular, and you need that for various important functions. You all know this, but we'll quickly whiz through this. So 25-hydroxyvitamin D, very important. Active vitamin D, very important. Increases calcium and phosphate absorption, and that maintains calcium levels. And a very, very robust mechanism of sensing the calcium through calcium sensing receptors, and that then allows the calcium concentration to be maintained. The parathyroid concentration changes based on the calcium levels, and that maintains. And this works very well if there is adequate amount of calcium and phosphate absorption. It doesn't work well when there is vitamin D deficiency or if there is decreased calcium in the diet. And what happens when this occurs? When there is reduced amount of 25-hydroxyvitamin D, when there is reduced amount of dietary calcium, there's a potential for the serum calcium to go down. But as I mentioned previously, the body doesn't like it. It wants to maintain calcium within the normal range, and it will do whatever it takes to do that. And what it does is that it increases parathyroid hormone secretion. And one of the important function is to increase 1-alpha hydroxylase activity, producing more 1,25-dihydroxyvitamin D. But it doesn't work if there is vitamin D deficiency and if there is dietary calcium deficiency, but it just can't increase the calcium levels. So what it does is that it mobilizes calcium and phosphate from the bones. Good. and that can normalize the calcium values. But the problem here is that PTH cannot mobilize calcium alone. It mobilizes both calcium and phosphate. And as I mentioned previously, that phosphate then binds to the calcium and doesn't allow the ionized calcium to go up. So what Mother Nature has done is that it excretes phosphate in the urine. And that's where the PTH is important, because what it does is that, yes, it mobilizes calcium and phosphate, but it can't keep calcium alone because the phosphate is also there. So what it does is it excretes phosphate in the urine. So what you see is a normal serum calcium and a reduced serum phosphate. And that's where the problem occurs if you don't measure PTH, because then you wouldn't know what exactly is happening to the system. Is it stressed? Is it the homeostatic mechanism is in full force? And therefore, measurement of PTH becomes very important. And unfortunately, in general pediatrics, that awareness is not there. So you see that the individuals will look into 25-hydroxyvitamin D and start treatment, but not concentrate on PTH levels. And how do we interpret vitamin D status? And this is all we have from the consensus recommendations. There are some recommendations of using 30 nanograms per ml, which would be 75 nanomoles per liter. But from my point of view, and I think the general consensus is for the skeletal health, 50 nanomoles per liter or 20 nanograms per ml should be sufficient. And when it comes to insufficiency and deficiency, it doesn't mean much. It doesn't mean much. You can, whatever it is, it doesn't mean in isolation much. You need to take other things into consideration, and that is dietary calcium intake. Because if you have vitamin D deficient, have I pressed the wrong things? Can we get rid of this? No, I mean, okay, fine. So even if you are vitamin D deficient or insufficient, you can maintain the calcium homeostasis by having a reasonably good calcium intake. And therefore, it becomes very important that you take a dietary calcium history. That's very important. Otherwise, you won't understand what the vitamin D level means. And also measure PTH, because that allows us to find out how much the system is stressed and how much the system has to work hard to mobilize calcium values. And again, this is where it becomes very important that you take dietary intake of calcium. If you start measuring vitamin D, 80–90% of the population throughout the world will be deficient. But that doesn't mean that we start treating them. What is important is, are there any musculoskeletal symptoms, and are they truly because of vitamin D deficiency? Because in that case, you will start seeing biochemical changes, at least the PTH should go up. And therefore, the dietary intake of calcium becomes very important, and you've got to combine all this together when you have a patient, when you're assessing for vitamin D deficiency. And again, a case scenario, I'll just allow you to look. I do teaching with orthopedic colleague. I teach them about vitamin D deficiency and how to manage. The problem is, the more I teach, the more they refer to me. So I just don't find it very useful because, you know a lot, so take over. So here, a 12-year-old boy, non-specific symptoms, refer to the orthopedics, and they say, well, vitamin D deficiency, here you go, you can manage this. Right, now what you see here is that, yes, there is vitamin D deficiency, but you have calcium, which is normal, but that doesn't mean much, because calcium could be normal if the homeostasis mechanism is stressed. Phosphate is normal, which is good, which is interesting, and let's keep that in mind, that phosphate is normal. Alkaline phosphate looks great. So really, from the biochemistry what we have, yes, there is vitamin D deficiency, but doesn't seem to be much problem with that low vitamin D here. And PTH then supports it, and they don't never measure PTH. And when you measure PTH, they don't even have to refer to me. They can just advise them healthy lifestyle and take over-the-counter vitamin D supplementation and sort this out. So if the PTH is normal, why low vitamin D is not a problem in this child? Yeah, exactly. And this is where we had a medical student who said, I want to do a project. I said, well, let's do this. And we picked up these products, and we said, well, let's do a 3-day diary and let's do a spot analysis and see how it correlated. And it correlated very well. And what you do is that it's mainly dairy products heavy, because that's the rich source of calcium. Milk, cheese, yogurt. In UK, bread is fortified, so we do ask that. Vegetables, nobody eats vegetables. I don't know, different. That is waste of time putting it there, but we did put it there, and this is really good, because you can then know within a minute or two how much the calcium intake is there. And this boy was eating plenty of milk, plenty of cheese, yogurt, and as I mentioned, no vegetable. So clearly you can see that the vitamin D is insufficient or deficient, but he has got a reasonably good calcium intake, and especially from the diet. And that's where, if there is adequate dietary intake of calcium, that compensates for vitamin D deficiency. And that's why the vitamin D deficiency is rampant, but you don't see that much problem with that vitamin D deficiency, because that is compensated by increased dietary calcium intake. That's not but that's, not every country is fortunate, and not every individual is fortunate. There are, individuals in Africa and Southeast Asia where it's not easy to get calcium intake from dairy products. And this is a really good study, and I always quote this one. And you look at this study of individuals from Delhi, from rickets and healthy control. And and what you will clearly see is that there's not much of a difference between the vitamin D here. It's not significant, the difference. But what is very clear is the dietary intake of calcium, and that too from the dairy products. And that clearly shows that, two group, good dairy intake, no problem with rickets, but the moment the dairy intake goes down and the calcium intake goes down, rickets develop. Very clear sign. And that is why dietary intake of calcium becomes very important. Just ask them. And a lot of children are intolerant to dairy. They say, well, we'll drink soya milk. Yeah, and it's almost all soya milk is fortified, but then it's got fiber in it. So yes, it's great, you got some calcium, but it's got fiber in it. Well, we'll take a tablet of calcium. Yes, you can take a tablet of calcium, but how much calcium is absorbed from there? Not much. So always encourage that take dairy as much as possible. A lot of individuals are intolerant to dairy. Then you take yogurt, you take curd, because it's much better. Obviously, if these all fail and there is allergy to cow's milk, then you can look into various other sources. So again, this is all about dietary intake. Right, I'm going to go into hypocalcemia. This is my approach. Everybody will have different approaches, and let's see how we go. So symptoms-wise, you're all aware of all the symptoms. Generally, these are the ones which tends to be when it is quite severe and quite acute, and tends to be more in neonates and infants, whereas in most cases you will pick them up in the early stages. They will come to medical attention. And again, very important with hypocalcemia is, okay, I haven't got that slide here, how quickly the calcium falls down. So I've got individuals who's 12 years old, and I'll present a case where the calcium level is 1.25, and they just come with tingling, numbness, and severe cramps. Nothing at all, no problem at all. Whereas there are individuals who have had calcium of 1.8 and then become symptomatic because there's a sudden drop for whatever reason, mainly during neonates and infancy. So it's not about the calcium levels itself. The symptoms also depends on how quickly, how chronic the calcium levels have dropped down over a period of time. That's my approach. And again, the magnesium concentration should be normal to be able to assess that. But I have to say that in acute hypocalcemia, measured magnesium, most occasions it's low. I've never been able to explain this, but maybe there is some link with the calcium sensing and the magnesium sensing. But on most occasions, it's low. And I do give magnesium, and the moment you sort out the hypoparathyroidism, pseudohypoparathyroidism, magnesium just normalizes, and then you can withdraw. Now, I tend to look at the serum phosphate, and again, it's not always, you've got to have there are some limitations to that, but I tend to look at serum phosphate concentration and then work myself up. If anybody has hypocalcemia, I straight away look at the phosphate concentration, because PTH excretes phosphate in the urine. So if the phosphate is low, you would know that there is increased amount of PTH secretion. And along with that, the alkaline phosphatase goes up. So you're mainly looking at vitamin D related disorders. And you're looking at the plasma 25 hydroxy vitamin D plus dietary intake of calcium as well, because that's very important. And that's where most of those cases will go. There will be vitamin D deficiency, then you can do other investigations to confirm that. Obviously, if you've got a reasonably good amount of 25 hydroxy vitamin D, the pathway is looking at the rarer causes, the genetic causes. But then again, the population is quite vitamin D deficient. So therefore, always, you got to correct vitamin D to be able to see which pathway they go. And I'll illustrate that in the cases as well. And if the PTH is low or it's not effective, as in hypoparathyroidism and pseudo-hypoparathyroidism, the PTH won't be able to excrete phosphate in the urine, and therefore what you will get is high phosphate levels. And there are some limitations which I'll discuss in some of my cases here. So that's how I approach my patients with hypocalcemia. And again, you need time. You need time. For example, not all investigations are available straight away. You will have calcium phosphate, alkaline phosphate, and that's it. Nobody will do PTH routinely. Vitamin D takes time in most of the labs. So while you keep an open mind, start giving treatment, and then work your way through as the results come through. Okay. Right, so I'll bring in some cases here. 15-year-old girl presents with 1.25 with cramps, tetany, trembling, no seizures, just comes to accident and emergency. Vitamin D, again, wasn't available at that time, but it came through fairly quickly. It was 19.1. Alkaline phosphatase is a bit high. What would you look at? Yeah, you will look at phosphate. Anything else, history-wise, anything you will ask? Very good. Again, very important that the child is there, the results are coming through, but you've got to make sure that have you checked the dietary calcium intake. Loves to eat dairy products. Oh dear, okay, fine. Loves to eat dairy products, so that 19.1 is not that bad. Alk phos is a bit elevated, but really, I am not looking at a severe dietary calcium intake to cause a calcium of 1.25. That's quite low. And it appears to be chronic as well. Right, so I do look at phosphate to see what exactly is happening in the phosphate. And that's where I find that the phosphate is high. So what are you thinking of more? Yeah, so it's most functional, isn't it? So you're looking at functional hypoparathyroidism, and then you're looking at either hypoparathyroidism or pseudo-hypoparathyroidism. So I've got a PTH, which is 15.2. So, we always say that even if the PTH is normal and the calcium is low, you've got to think about that, it is relatively hypoparathyroid. And here you actually got parathyroid hormone levels high. And I've never come across a hypoparathyroidism where the PTH is higher. It's usually low, or on the lower end of the normal range in partial or low. It never even in the higher end of the normal range. So you're mainly looking at pseudo-hypoparathyroidism in this case. And again, with this vitamin D, with this alkaline phosphatase, we would have thought that, yes, this looks pretty much like vitamin D deficiency, let's move on. But no, if you take history and if you look into other parameters, you will see that this is pseudo-hypoparathyroidism. However, beware. The severe dietary calcium deficiency can mimic pseudo-hypoparathyroidism. And I had a patient who came in and he had a classic Trousius sign. He was in A&E and all the trainees went in and tapped him and he got so tired. He said, I want to sleep now. And next day I had all these results, the PTH and phosphate. I thought, well, this looks like pseudo. And he was autistic. I said, anything with the milk goes in the bin. And I thought, okay, fine. Let's not jump into conclusion. Treated vitamin D, gave him loads of everything settled down. So I think it's very important that the pseudo-hypoparathyroidism calcium deficiency can mimic pseudo-hypoparathyroidism. So therefore, in all such cases, you got to be aware of this. But this looks quite convincing with a very good dietary intake of calcium. So with history, with the basic investigations, you should be able to come to a diagnosis. and she did turn out to be pseudo-hypoparathyroidism type 1B. And again, with 1A, you start seeing all the features of Albright's hereditary osteodystrophy. Type 1A, in my experience, presents a bit early, but then it has so happened that once you look into all the cases, you suddenly see that actually there's so much overlap. And I didn't realize till Ashima, one of the consultant here in MAMC, came over to work with us, and she collected all the cases. And I realized that actually almost 50 to 60% of our pseudo-hypoparathyroidism 1B, because of methylation defect, there was overlap. Some had learning difficulties, some had hypothyroidism, and some had even asymmetry of the skeletal manifestation, with one side of the limbs having the short third and fourth metacarpal, whereas they're not the other one. So this is classic 1A. You would see this, and again, subcutaneous calcification. So this is all 1A. The one I presented was 1B. Right, so this is what it is with 1B, but as I mentioned, there can be a lot of overlap here with learning as well. Right, now this was again orthopedics, waddling gait, reduced distance of walking, unable to run and jump, and this is what I have, biochemistry. He's 5 years old. Yeah, so I've got a calcium, which is low. I've got a phosphate, which is high. I've got an ALP, which is high. I've got a PTH, which is elevated. I've got a vitamin D, which is undetectable. And I think you probably, yeah.
Even in the previous case,
yeah.
when you see a high phosphate, wouldn't you do a serum creatinine before you go to functional hypoparathyroidism?
To looking at the renal failure. Yeah, absolutely. Yeah. And what we have,
like us, I think we need to
yeah,
rule that out first.
Absolutely, I completely agree. I missed that part. Usually, our profile comes with use and ease, urea and electrolyte with bone, so I don't tend to concentrate. But you're right. You got to look at the renal failure as well, because that can increase the phosphate values. Yeah. So here you got, and then you wonder, why is the phosphate high? And as I discussed, you've got hypocalcemia, you've got PTH, which is elevated. You've got alkaline phosphatase also significantly elevated. And this is where it became important. So next year, in the ward round, this is the history you get. I've never seen anybody do this. They'll pick out cereal from the milk, wash it with water before eating them. Very severe dietary calcium deficiency. And this is where you see that the PTH levels are elevated. Okay, and this is Mother Nature's way of protecting the bones. And very interesting radiographs. Look at this. With a 1.25 of calcium, with alkaline phosphatase elevated significantly, yes, I do see rickets, but not the kind of deformities I should have seen in a patient with such severe vitamin D deficiency, with a calcium of 1.25 and the alkaline phosphatase elevated. So very clearly, the Mother Nature has protected his bones, and the severe dietary calcium, that is what happens. It mimics pseudo-hypoparathyroidism. That's Mother Nature's way of doing things. So it's very important that you take that history, because the treatment is mainly dietary calcium, plenty of calcium. In this case, he had significant allergies, so we had to give him a lot of oral calcium. He's now 10 years old and still comes with the same kind of biochemistry again and again, because he just doesn't tolerate his oral calcium medications that well. He can't tolerate his milk. Right, okay. Now, 14-year-old, reduced mobility over 2 months. Again, orthopedics, stopped walking, and the orthopedics did x-ray of the hip. I mean, look at those neck of the femur. And the CT looks horrendous. I couldn't appreciate that much on x-ray of the hip. But when I look at the femur there and the neck completely squashed, head of the femur completely squashed. And that's the degree of disability he had. And the surgeons said, well, great. Surgeons love challenges, don't they? Straight away, we will go to the theater, we will fix you, you can go home very quickly. Great. But the anesthetists and surgeons, they never get along very well in government setting. The private, they do very well, but in the government setting, they don't, because they always antagonize each other. But the anesthetist said, no, I'm not going to take this patient to the theater because you've got an abnormal biochemistry here. You've got calcium, which is 2, you've got alkaline phosphatase, which is elevated, you've got phosphate, which is normal, and the parathyroid hormone is elevated. Again, you can see that what has happened. So what exactly is going on here? And again, very similar. Why is the phosphate not low here? His vitamin D completely undetectable. And when you look into his X-ray of the hand, we did it for ricket. Yes, you do see those changes there. It's very hard when the growth plates are fusing to appreciate rickets. The margins are quite clear, but they are a bit crooked. Surgery postponed, transfer to our hospital, severe autism. That's the problem, very severe autism. Only eats potato chips with vinegar. And the vinegar was very helpful for me because most of these patients come with vitamin C deficiency. But he was taking plenty of vinegar with potato chips, so that one problem wasn't there. And what we did was we started vitamin D and gave plenty of oral calcium to him, and then started introducing dairy products. It wasn't that he had allergy or intolerance, it just needed time to be able to get used to calcium. So got the psychologist, play therapist, and psychiatrist, everybody involved. And then after 2 months of treatment, bone biochemistry normal, the surgeon said, could we take this patient? I said, yes. The reason, if we did the procedure before, it would have failed because there was significant osteomalacia there. But now we have healed osteomalacia, and the procedure was much better. So we continued that. So they had to do osteotomy. And that's the problem in this age group, that you have to correct deformities, you will have to do osteotomies. And they are significant. Yeah. 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 Why the ALP is not that elevated? Yeah. Yeah, and that's where the resistance of PTH. The PTH resistance is not allowing the bone turnover, which would happen if the PTH was elevated. And that's one of the things which happens here. And again, when does PTH resistance occur? There are different stages of rickets, 1, 2, 3, 4. When it occurs, it's not yet clear because it's not still been described that well in medical literature. Because some of the patients do have rickets. So they say it can happen in stage 1, but then they shouldn't develop ricket. They have already developed rickets, some of them. So it's hard to say what stage it develops. And then he had osteotomy, and this is after a few months, and he needed epiphysiodiasis as well. Again, growth plate aren't there, but the surgeons thought, well, we'll try to see if we can try to correct this as well. Okay, fine. So I'll move into another case of hypocalcemia. Yeah, please.
Yeah, I have a comment about vitamin C deficiency, what you said.
Yeah.
Our observation is also similar, that now with the current diets, the prevalence of vitamin C deficiency, it is again rising probably, and often it is overlooked while we are working up for the bone disorders.
Yeah.
And often once you supplement vitamin C, a lot of symptoms they improve.
Absolutely, I completely agree. Because of the ARFID, the restricted feeding habits, we have seen a increase in vitamin C, and it's important that you recognize that. Very good point. Right. So this boy, 1.95 of calcium, hypocalcemia, and I've said rickets, so he has got rickets. His phosphate is low, so you get a clue that this is look more. Alkaline phosphatase elevated, again looking good. His PTH is high, so everything pointing towards the vitamin D pathway. His vitamin D is very good. So, he's not vitamin D deficient. He's actually got plenty of vitamin D there. And very good, and on calcium supplementation. What else would you measure here? Yeah, and I heard about 125. Very good. So it's a special request in our lab. You've got to tell the lab to do it, otherwise they will throw the sample because people, instead of 25, request 125. So we did that, and this is what we had. So quite high 125 dihydroxyvitamin D levels. So what are your thoughts? Yeah, yeah. So what we have is, yes, you're pointing towards the head. I presume you're not talking about brain, something else. So you have a very high. So this looks towards the vitamin D dependent rickets type 2A. Type 1, you would have found the 125 to be lower. So that's what you have here. And it did come out as vitamin D dependent rickets, homozygous. And the important thing I was looking was, is it in the ligand binding domain or the DNA binding domain? Because it changes the picture. And you know why? Because the ligand binding tends to be, the severity is less compared to the DNA binding. So this is the vitamin D receptor, and then the ligand binding domain is there, and that's where the 125 goes and binds, and that this is the DNA binding domain. And what VDR does is that it goes and binds to the promoter region of hundreds of genes, and it then promotes expression of those genes. So if the mutation is in the DNA binding domain, it tends to be much more severe than those if the mutation's in the ligand binding domain. And that's why it becomes important to look into the genetics to see which way this would go. And look at the x-rays here. Quite severe rickets on the wrist x-ray, and the knee x-ray as well. You can see quite severe rickets. And he also had previous fractures, so therefore he has quite a significant deformity. He came a bit late because he migrated from Morocco. So it wasn't that we didn't pick him up early. And this is his clinical picture. You can see significant deformity. What we were very worried about was that he had a very narrow thoracic cage. These pictures don't do justice to the narrowness of his cage, and we were very worried that if he has any respiratory infection, he will struggle. And again, very typical, the hypotonia and then pot belly. And he did have hairs, but very sparse, very sparse. They're very long, and therefore it's hidden, but you could see that they were very sparse, his hairs. So that is one of the characteristics of DNA binding domain, that they have alopecia. In his case, he didn't have complete alopecia, but you can see that the hairs were sparse. So he was given oral calcium. He was on alpha calcidol, and I have to say that the 125 we measured was on alpha calcidol. So we got the diagnosis, but the alpha calcidol would have been elevated with the alpha calcidol he is on, and he was on cholecalciferol already. So what we thought was that, well, let's give him a good oral dose of calcium, because quite a few of them we can manage with oral calcium. So gave him 1.5 grams oral QDS of calcium, but 2 months post-treatment, not much change at all. So we've still got calcium to be low. He wasn't symptomatic. We got calcium to be low. His alkaline phosphatase is high. If at all things had worsened, what would you do next? What would you do next? IV calcium. Perfect. So what we did was that we started IV calcium. And again, I put graphs separately because I couldn't combine all of them together. Now, when we start IV calcium, what is our aim? It is not to normalize calcium. And you can see very clearly that within few days, we were within the normal range of calcium. That wasn't a problem. So it's not that I am giving IV calcium to normalize calcium levels. My main aim of giving IV calcium is, so what causes rickets? Exactly, phosphate, right? That is what is causing rickets. My main aim is to normalize phosphate. How can I normalize phosphate? Yeah, I need to drop it. Don't give phosphate. That's going to make, it will be very challenging, because as I mentioned, you give phosphate, the calcium will further drop, the PTH will go up further. So my main is to normalize PTH. And that is what we did. That is what we did. So we started with 8.8 millimoles of IV calcium. We gave it over 12 hours at night, and then on the day, you're free. And we tried to get the home infusion set up as well. It takes a long time in UK to get the home infusion. Our aim was to give him for as long as it is needed. And we were not sure how long it will take. We were not sure that how long it will take for us to get the PTH normal, phosphate normal by giving IV calcium infusions. So we started with 8.8, and then we went up to 30 millimoles a day. That is a massive dose. And this patient, the ward was not happy to keep. No, we can't keep on such high calcium dose. Had to go to high dependency unit. And then once they were happy, yeah, he's tolerating 30, get back to the ward. And that's what we did. So eventually we came down to 10 millimoles a day, was sent home. And then, we were at 4 millimoles a day at one point at home. All this time I was giving oral calcium supplementation because ultimately when he stops IV, I want him to be on oral calcium supplementation. And when I found that the PTH is very stable, and I stopped IV calcium infusion. What else would prompt me to stop IV calcium infusion here? I mean, obviously the PTH is normal. I carried on giving IV calcium for a while, even when the PTH was normal. What else should you be monitoring where you say, no, we need to stop IV calcium infusion now? Yes, that's fine, but it was normal. Anything else? Yeah, something coming from here. Urine calcium creatinine ratio. Absolutely right. In fact, he developed a bit of nephrocalcinosis. I did that. So that is important. So we were measuring urine calcium, and this point, you started leaking. That meant that the bones were not anymore hungry. They said, fine, if you're giving me more calcium, I'm going to leak it out in the urine. And that's where I stopped it. And I was very worried that what will happen? Will everything come back? And this is what happened. We sent him home. I mean, he was at home, IV calcium infusion. We stopped it, and then he was on a good going dose of all this medication. And very good family, and school as well, very good, because they would give some of the doses at school. That was very helpful. And the whole purpose is to normalize phosphate. And we did get phosphate fairly quickly under the control. But once the phosphate is normal, you know that the ricket process won't happen, and the healing will start. And that's what we did. Do not give oral phosphate, please, because that is very common. Phosphate is low, that causes rickets. Give phosphate. Very interesting that if you can't control the PTH despite IV calcium, you could do something else. What is that? And there are case reports of that. Fantastic. Very good. You know everything. Cinacalcet, and that has been used. So if you have IV calcium and you still feel the PTH is not coming down, then you can give cinacalcet. But be careful, because that cinacalcet can cause hypocalcemia. Not in other conditions, but in those conditions, it can cause hypocalcemia. Well, his magnesium was low, and VDDR2, the magnesium can be low. So that's why we had given.
How frequently was your PTH?
Good point. It doesn't matter. I mean, you could do weekly or 2 weekly. Or you.
How did the IV calcium?
It went for, I think, 9 months to 1 year. Not full 24 hours, it was 12 hours. And that's why it was set up for home, because you could get it at home, sleeps, gets it, goes to school, comes back. It does require, and again, you don't have to give this much for this long. You could give it intermittently over a period of time, and then you need a central line. And he had a Hickman line in the central line, because it's a huge undertaking. I'm not saying that it's an easy thing to do, but we had to do it because the oral calcium wasn't working at all. And this is exceedingly rare case, but this is what. No, because once we know that this dose is being tolerated, it doesn't require it. And that's why people get very worried about it. And that's why he was in HDU. Every time we had to increase the dose, off you go into HDU, high dependency unit, because the ward won't take them. And therefore, yes, you do require cardiac monitoring, but once you've done that, that dose is fine.
Sorry, a very basic question.
Yeah.
So in hypocalcemic rickets,
Yeah.
In hypocalcemic rickets, a very young child, say a toddler, what is the dose of calcium that you will supplement?
I'm going to come to that.
Sure.
Please do not ask me doses. I just don't know. My trainee knows more about doses than me because I just pluck up from the whatever it feels like and start it. You start something and then you monitor. It's very individualized. Alpha calcidol dose, do not ask me. I do not know the doses. I will say, okay, this child, this much hypocalcemia at this age, let's start with this and see what happens. I'll give you some doses. I knew this question will come up. Right. So normalized PTH, and this is what we got. This is after a few years of oral calcium as well. We got fantastic results here, isn't it? And I may need to give IV calcium again during puberty, and I may not need to. Hopefully I won't. This is great. You see the images. He still has got some deformities, but they should get better. And again, you see this 3.5 and 7.5 years. You could see the difference there. And you can see that the scar from his central line. And it's not easy. He used to get infections from the central line as well. So it's a huge undertaking. And again, it's not possible in every part of the world, but you may have to do that just because it becomes very difficult to manage DNA binding domain. Growth, fantastic. Weight increase, height increased. So, overall, he is a very happy child and he just enjoys running around at school and doing what all children of this age should be doing. So, yes, there are some doses for you there. And I have just picked up from our British National Formulary and put it there. One thing I want to tell you is that it's not uncommon for me to go to the intensive care unit in the morning and they telling me, I've got a patient with hypocalcemia, we've given 3 boluses of calcium and the calcium is still low. What do I tell them? Do not give multiple boluses. If one bolus doesn't work, just start continuous. It is not helpful to give bolus after bolus. Just give continuous infusion. A bolus of IV calcium more so that the symptoms are sorted out because they've got this seizures happening and various other things, apnea can occur. So give that bolus to sort that symptoms out. And if you feel that the calcium is dropping down again, don't keep going bolus after bolus. Give continuous infusion. And the max according to the British National Formulary is 8.8 at any age group. And beyond that, if I have to give anything, I need to transfer to HDU because they won't take. Right. And a few more things I wanted to tell. In hypoparathyroidism, we keep it between 2 to 2.2 because otherwise they lose calcium in the urine. But for pseudo, we don't. We don't. I mean, I used to when I started practice 15 years ago, and then I realized that actually I don't need to because my main aim is to normalize phosphate and PTH, and that requires high doses. And pseudo-hypo, exceedingly rare to develop nephrocalcinosis. They don't. So please give them generous amount of alpha calcidol. Okay. Now I forgot to put one thing, but it's not come up in this version. I personally don't manage hypo and pseudo with oral calcium supplementation. I don't. My advice is just give plenty of milk, cheese, and yogurt. I don't give oral calcium unless there is allergy and various other problems. The reason being that alpha calcidol, or you use calcitriol twice a day, 3 doses of oral calcium or even 1 dose, it's not required. You give as much possible of alpha calcidol and calcitriol to maintain calcium levels and let the child eat plenty of dairy products. Only when you have serious concerns about the dietary intake of dairy products, then you introduce calcium because you really don't want them to have 4 doses of medications throughout their life when you can just manage with 1 dose of alpha calcidol. So my practice, and we are just reviewing that, and we're going to publish that as well, that most of our patients we have managed very well with alpha calcidol medication or calcitriol. And then there are some doses of alpha calcidol, and as I mentioned, I don't look at that. Yes, please.
Urinary calcium creatinine.
Yeah.
This is a mid-childhood age child.
Yes. Yeah.
Is it
Yeah. I mean, I agree. I think it's 0.4 as well, isn't it, or 0.5? Yeah, 0.3. Completely agree. Yeah.
Can we go as high as?
That's our lab's results. But I complete, and I think I find spot urine calcium again difficult.
I think it's in millimole. I think
Say that again.
it's in millimole. In milligram per dl, it's different.
No, I think it's the same because it's a ratio. It's the same. Now the problem is that the best is 24-hour collection, and it is incredibly difficult to do that. In our practice, you got to do spot urine, and the spot urine can give you various results. And therefore, the nephrocalcinosis part becomes very important. So that's why the ultrasound scan yearly becomes quite important. Some may argue that why do you do it yearly? You could do it too early. What we do is that we do yearly because we want to make sure that if there is nephrocalcinosis, and it happens with GCMB2 mutation with alpha, which is quite severe, autosomal recessive, and the calcium sensing receptor as well, you do get quite a bit of nephrocalcinosis. So we do tend to do more frequently. Any questions about hypocalcemia? I didn't in particular go into hypoparathyroid cases because I just thought that maybe these are more challenging. Yeah, there's a question there. Yeah, so when do you add hydrochlorothiazide? Good point. I mean, I speak to my nephrology colleagues, say, what do? I'm getting a bit more urine excretion, there's nephrocalcinosis. They said, first of all, low salt diet. Second of all, 2 to 3 liters of water, and then introduce chlorothiazide. It's not that effective, but you can do that. Physiologically and pharmacologically, it makes sense. So you can introduce that if you feel that the nephrocalcinosis is a problem, especially in cases of severe hypoparathyroidism, GCMB2 mutations, calcium sensing receptors. You can introduce that. That's a good point. Yeah.
Maybe a little unrelated.
Yeah.
But thanks. So, but in children with neuromuscular conditions who have limited mobility, would you restrict the calcium supplementation a little bit?
Yeah, absolutely.
And
again, the nephrocalcinosis, the urine excretion of calcium helps. Most of those with dismobility,
for example, DMDs.
Yeah, absolutely. I agree with you that they excrete more calcium, and sometimes we give more calcium than they need to be. You're right. And cerebral palsy patients, and usually they get milk through the tube. They've got plenty of calcium intake.
So something like alternate day supplementation would help, you think?
Yeah, well, they don't need it.
Okay.
They don't need it because they've got plenty of oral calcium intake.
But they need vitamin D.
Yeah,
so
they
the
do.
problem with them is vitamin D rather than calcium.
Yeah, I agree.
So they're not exposed to sun. A lot of them are non-ambulatory. How much do you supplement? So that becomes difficult. You have to keep monitoring.
Yeah.
You have to monitor and give, because if you give more vitamin D to them, again, they can have problems with the excretion of calcium, again leading to nephrocalcinosis and hypercalciuria. So you really have to monitor and give.
And again, our cerebral palsy patients who get fortified milk all are loaded with vitamin D as well. So we really struggle in those patients. That you monitor and you decide what you need to do.
Is there anything to choose between alpha calcidol and calcitriol? What is
Again,
your
the
opinion?
half-life. And my friends in Germany say, you give alpha calcidol, we give calcitriol. Calcitriol is costly. You do a better job. I said, yes, we do a better job. We do alpha calcidol. It's once a day. In fact, the half-life is more than 24 hours. It's even 48 hours, 72 hours. So sometimes if they forget, I say, take 2 next day. So that's why we prefer alpha calcidol, but again, calcitriol, alpha calcidol equally good. Yeah, exactly. You use what is more cost effective for us. For us, calcitriol is costly. Right. I am going to quickly go through. Do we have time? We've got only 10 minutes. So what I'll do is that I'll quickly go through some cases. Again, there is a pathway there, but this is one of the challenging cases we had. And again, in this, you in hypercalcemia, you got to look at PTH. That's what it is. The approach is mainly look at PTH, high calcium PTH, and then if it is PTH dependent or not. And here we had all the features to suggest that there is a hyperparathyroidism going on. And then there was this ultrasound scan which did show some solid nodule, but our ENT surgeon said, I'm not very convinced. Would you do a PET CT scan? We did that, and that was negative. And we did do a lot of interventions to reduce the calcium, and we had no imaging which was positive. And the surgeon went in, tried to do his best to take something out. I don't think he took anything out. We sent to the histologist, said, well, we can't see any parathyroid gland there. So we were left with a situation where within 3 days the calcium had gone up, and he said, I can go back within 7 days. I said, no, please leave him alone, leave her alone, because I am very worried. Have I missed something like FHH here? And it's very important because if FHH have vitamin D deficiency, the PTH goes up. They're very sensitive. Unlike us, they are very sensitive to vitamin D. Their vitamin D goes down to, say, 15 nanograms per ml, the PTH rises up. So all my FHH patients I see once a year just to make sure they're taking vitamin D. That's it. And I did that, and that was negative. I said, well, do a CT scan as well, and that was negative as well. And this is where we have a bit of experience. We've got around 5 or 6 patients where we couldn't localize, and we've done the selective venous sampling. And what you would see is that clearly it's coming from somewhere on the right lower part, right upper part, right upper part actually. And this then helps the surgeon, okay, I need to concentrate in that area and find out what exactly is going on. And this is where he found out the retropharyngeal area, and this is a very notorious place. This is one area where actually localization is not easy. And this was one of the cases where localization became very difficult, and we had to do a selective venous sampling. So that's one of the modalities which we have used for hypercalcemia patients. This one is an interesting one. Came through safeguarding route. You know, any fracture in infants and neonates, that's it in the UK. It's a challenge. So this boy had 10 days old and had a fracture there. What's going on here? So we've got hypercalcemia, we've got PTH high. So what should I be thinking of? Yeah, neonatal hyperparathyroidism. 2.9. And what was the symptoms? Normal delivery, limited movement of right arm for 2 days. I asked, is there any signs of dehydration? They said, no. Is the baby feeding well? Yeah. Otherwise, absolutely fine, just the limb and maybe a bit of the lower limb as well, where there is a problem. I said, okay. They safeguarding straight away. That's what happens. And this is what was the problem. Taken into care. Corner fractures, very, very characteristic of safeguarding. You don't get it anywhere else. You really don't get it. In OI, anywhere, you don't get corner fractures. And that was like, okay, off into care. You see this fracture, very, demineralized bones. And again, it becomes important to check what happens with the father and mother. So dad has got, what do you think dad has? What do you think dad has? FHH. What does mother have? Okay, now, can anybody tell me what exactly was happening in this baby? When the baby was in fetus and after the baby was born, what exactly was happening? Sorry?
He has one variant derived from father. Then because he had hypertrophic gland during gestation.
Can you use the mic? Yeah. Yeah.
It's autosomal dominant only, but because mother's calcium was normal,
Yeah.
so it was not adequate for him. So he's granted but hypertrophied. So
Yeah.
after birth, it hypercalcemia manifested.
Fantastic. So basically, this fetus wanted a calcium of 3.2. What was this fetus getting from mother? 2.2. Does it like it? No. What does the fetus do? Pumps up PTH secretion and then chews all the bone. And the bones are completely demineralized, very hungry. How would you manage this? Give him vitamin D and calcium. Will the neonatal doctor agree with me? He will say, I'm going to report you to General Medical Council. Sorry? Cinacalcet, fantastic. But I did tell the neonatal doctor, give calcium. And he did ring my colleague to say, are you sure he's saying the right thing? And this is what we discussed. So oral calcium supplementation is Cinacalcet. In this one, I didn't have to. So his mutation came positive. I actually just gave him oral calcium supplementation. I could give Cinacalcet. The reason I didn't go for Cinacalcet is because I felt that he's probably not that symptomatic, and my role wasn't to bring I should have probably done both, but I just went for calcium and then see how it goes. And actually, he did reasonably well. At 3 months of age, his bones were normalized, and I think that all settled it. But you're right, Cinacalcet would be the right thing to do as well. You could give both. His bones are hungry, and I thought just giving calcium for those hungry bones will settle it down. I did monitor calcium to make sure it was not going to 3.5 or 3.6, but it just remained what it was. It allowed the PTH to come down. Right, now this is very recent, and I think it'll be good to discuss this. What do you think? 13-year-old. Toxicity, very good. I think we should consider that, vitamin D toxicity. Anything else, please? I needed to give IV pamidronate, 1 milligram per kg per dose, and that reduced the calcium, but she became hypocalcemic. She wasn't taking much vitamin D from the history. So I needed to start oral calcium and calciferol. This is very important, and that's where we struggle a bit, because in the blood there was nothing. In the aspirate there was nothing, but they had to do a biopsy to get that very early stages of lymphoblastic. It's really the earliest. If she didn't develop hypocalcemia, she would have come with the disease maybe 6 months later. And that's something which we have seen in quite a few of our patients, where the oncologists say, please, no, nothing to do with us. We don't want to deal with this. I said, no, please, there's nothing we can find. Everything looks okay. And this is where it becomes very important that you think about. And there are, the registries have been studied to see, and it is not uncommon. The malignancies can present with hypocalcemia. It will be good to measure PTH-RP, but we don't have assay. We got to send it somewhere, and we didn't do it. But I think it probably mediated through PTH-RP. Right, this is the one where there is the registry of all the patients, and they looked into cancer patient, and the prevalence of hypocalcemia ranged from 0.24 to 0.81 between 2003 to 2014. So it does happen. It does happen. So you got to think about, so hypocalcemia, no vitamin D toxicity, you got to think of malignancies as well. And one of our other patients actually presented with multiple vertebral fracture as well, along with this. Right. 3-week-old infant, hypocalcemia, blood tests for prolonged jaundice. Completely asymptomatic, had prolonged jaundice, so had a blood test done. What should I look at? Calcium, which is 3.06. PTH is suppressed. What would you think of?
I had a case, so I can cheat and tell you the answer.
Okay. Okay, we'll see. Calcium creatinine a bit high, but again, these values are not for the neonate. Rest of the biochemistry was completely normal. Clinically asymptomatic. And that was very important. And we have seen quite a few where we have stopped breastfeeding. Oh, did I reveal the answer? There are no features of nephrocalcemia. Whenever you have a neonate with hypercalcemia, do check the scan quickly by an expert. Because by the time you see hypercalcemia, nephrocalcinosis is already developed. It is very important. All the subcutaneous fat necrosis, common age is 2 weeks, 3 weeks. Nephrocalcinosis is there. Clinically asymptomatic, no nephrocalcinosis. What did I do? I stopped breastfeed, put them on Locozol, and everything settled down on its own. And this is where we're just putting this together, where we've collected all this breastfed, where we were said, you're crazy, what are you doing? I said, well, I'm doing the right thing. I'm continuing breastfeed. There's hardly much breastfeeding going on in UK, and I'm going to stop all these babies from getting breastfeed. And it settles down. It settles down, either when they move to formula or with time. And we don't know why this happens. And and really, I'm not saying that we should be measuring calcium in these infants, or we should discourage. No, please. This is the lesson is the breastfeeding needs to be continued. That's the best for the baby. Why does that happen? We don't know. I mean, again, just the data about our patients where the calcium levels were fairly high, but they all settled down. All of them had ultrasound. I'm so careful about these ones because I'm doing something which is not there in textbooks. I do nephrocalcin assessment more frequently. I just say that, our radiologist, please could you do it again in 2 weeks, 4 weeks, just to make sure that I'm not missing something else. And so far, when they give history of breastfeeding, I say, that's fine, I can wait and watch. And it's easy in UK because we've got a milk called Locozol, which is no calcium at all. And it's easy to give. Calcium will normalize quickly. Okay. Right, and we don't know why it's happening. We can't measure breast milk phosphate because it's not it requires a lot of preparation. We believe that this may be a mechanism, but we don't know. That the low phosphate is actually triggering it, but we don't know. We don't know about this one, but it's an interesting one. The reason I'm saying you need to recognize this is because if they're clinically asymptomatic and if there's no nephrocalcinosis, do not discourage breastfeeding. It's very important that you carry on. And they thrive well. That's important. The risk of discontinuation of breastfeeding becomes quite important here. Right, so we've discussed a few of those, the treatment of hypercalcemia. What I wanted to do was just quickly go through another case because this is just actually in our intensive care at the moment. And I thought it'll be
Then we never start breastfeeding in them.
Say that again?
Then we never start breastfeeding in them again.
No, we continue breastfeeding.
After?
No, we never discontinue breastfeeding.
Okay.
We don't discontinue breastfeeding.
You just checked that it is that only.
Yeah.
By giving formula for some time.
No, we don't do that. We just make sure there is no nephrocalcinosis. We make sure the baby is clinically asymptomatic, and that's it.
Okay, you told you switched to formula for some time?
No, in the past we used to do that, but not now. Now all of them are continued on breastfeeding. Oh, I'm really sorry. We don't discontinue breastfeeding. In the past, I used to do that, and then I realized actually I'm causing harm than benefit. Now you continue giving breastfeeding, and it settles down on its own. What I do is I make sure they're clinically asymptomatic. We've got health visitors who can do that, and also ultrasound scan for nephrocalcinosis, because by the time you recognize hypercalcemia, nephrocalcinosis is already developed. We have a recent case of subcutaneous fat necrosis, and the nephrocalcinosis was there even before we picked up things.
Slightly different scenario where the mom has
Hypercalcemia, yeah.
And baby presented, and then you want to give it high calcium.
Yeah.
And why didn't the baby on it normalized but reintroduced the breastfeeding?
So, yeah, I'm just going to, yeah. So your question is that the mother had high calcium, baby had high calcium, and then you did Locozol, and then
Normalized.
Yeah. Okay, well, I'm going to just break down into further. If mother has high calcium, that will circulate to the fetus. The fetus will suppress, so the baby will be hypocalcemic. So if the mother has high calcium and the baby has high calcium, what does that tell you? Baby has FHH. Okay, and in that case, if you give Locozol, it will make things worse, because that will make things worse. So again, when the mother has got high calcium, we always say when the baby is born, contact us, because they then start doing funny things. The neonatologist, they straight away ring as I say, okay, the mother has high calcium, the baby has got high calcium, then it is more likely to be FHH. And you won't believe there are so many adult patients with FHH where all 4 parathyroid have been removed.
She's been thoroughly investigated and they haven't found anything.
Fine. So again, with Locozol, again, the problem is that it can make things worse in FHH. Yeah. Okay. Right. So this is the one where Yeah, yeah. I'm absolutely sure this is the last one. So there was some incidental finding with an enlarged thyroid, and the routine blood showed 3.3. And again, I'll quickly go through. There is no problem with the diagnosis. It's very clear that this is what it is. Now, this is what happened with the X-rays. You can see that quite demineralized, and you can't see rickets here because it's very difficult. And rickets do develop because their phosphate is low. And that's one of the problems with hyperparathyroidism, that it can cause rickets because of low phosphate, and the PTH causes demineralization. And he had this insufficiency fractures as well. And then very clearly the gland was seen and had surgery. And this is where we landed up in trouble, where the calcium dropped down and wouldn't go up with oral calcium supplementation. So we had to give IV calcium. And every time we try to reduce the IV calcium, the PTH will go up. What I'm trying to highlight here is the hungry bone syndrome, which we haven't had that much experience in the past, but this patient was so long-standing with hyperparathyroidism, migrated from Pakistan to some European country, then came over, and then as a refugee for months together. His calcium was measured in January to be 3.8. Nobody picked it up, and then came to us in August with this amount of hypercalcemia. So what I'm trying to highlight here is that the hungry bone syndrome is very important. If you do parathyroid surgery, especially those who are presented late, they will be hungry bone, and therefore you will need to give a lot of IV calcium and making sure that the PTH normalizes. Okay? Yeah, we did. We did the alpha calcidol. We did try that, but it wouldn't come up. No. Right. So that's about the hungry bone syndrome. That's about it. I'm sorry it took longer than what was required, but I just felt that. If there's any questions you have, you can more than ask me now, or maybe catch up with me after the meeting. Thank you.
It's my pleasure. Anju requested me just now. Thank you
very
so
much.
much.
Thank you. Thank you very
Really
much.
nice.
Okay.
One more.
Sure.
Thank you.
Thank you. Thank you very much.